Welcome to the Movement Prescription Podcast. In today's episode, we're going to be joined by Craig Blain from Move Consulting, discussing the tricky business of embedding physical activity into primary care delivery. I think you'll find that in this episode, we have a really insightful conversation covering in particular areas around communication, including the terminology, the messaging, and how to frame our conversations with patients. We'll also delve into Craig's extensive experience in delivering projects and creating pathways for physical activity in a number of sectors, including the healthcare sector. Looking for tips when it comes to creating business plans and conducting service evaluations, as well as covering how you go about creating these pathways. And he'll reach out to explain how the client, the patient, should very much be the judge of the content for these sessions. He'll also share with us his miracle question, as well as delving into how we go about combating this problem-first culture, where patients attend with problems rather than us being equipped with a structure of healthcare where we can focus on preventative measures. I hope you find the episode useful. I know that I found it particularly insightful, and I've made a number of changes going forward based on our discussions. So, without further ado, I introduce the Movement Prescription Podcast, Craig Blain, How to Embed Physical Activity into Primary Care. Hello, Craig, and welcome to the Movement Prescription Podcast.
Hi, Hussein. Thanks for having me. It's good to be here.
Oh, it's great to have you. And I think to start off with, it'd be great if you could introduce yourself, a little bit about your role and the company that you work with, so that our listeners get an understanding of kind of where you sit.
Yeah, brilliant. So my name's Craig Blain. I'm the founder and director of an organisation called Move Consulting, and we are a physical activity related specialist organisation. What we're here to do is help organisations to think strategically about physical activity, how we can use that as a vehicle to achieve whatever your strategic outcomes might be. Now, that might be to support and maintain the health and well-being of the nation. It might be to improve the outputs of your workforce in their productivity. It might be to contribute to your local community in terms of service provision. Whatever it is, if physical activity is part of the solution, we're interested to talk to you. And we've worked with a whole host of different organisations in the time that we've been set up. We set ourselves up in 2020, and it's been a whirlwind of 3 years where we've done a whole range of work. But it's included things like working with the Chartered Society for Physiotherapy in helping them to understand how to position physiotherapy staff in delivering messaging around physical activity, particularly strength and balance. We've worked with a number of national governing bodies of sport and active partnerships in helping them to think strategically about developing their action plans and work that they're commissioning locally. And like I say, a whole range of work where there are so many ways in which physical activity can have a benefit. And it's what we do. We love to do the work we do, predominantly because we're speaking to people that are passionate about the same things we are.
That's fantastic to hear. And I suspect a lot of our listeners who are predominantly, staff from primary care, whether they be GPs, nurses, first contact physios, health and wellbeing coaches, we have a range, but they're all going to be based in primary care predominantly. Now, many of them, they're passionate about physical activity. They know the benefits. Some, extract those benefits for themselves, but they get to a bit of a stump when it comes to how do we engage our patients to get more active, especially as there's more and more growing evidence that it's really beneficial for long-term health conditions. And long-term health conditions are very much the sort of talk of a lot of the sort of healthcare, both workforce and senior positions within government. It's a growing problem. Now, have you done much work sort of within primary care, sort of working at these kind of things and setting up these projects? Any examples that you could maybe share with us and go in a bit more detail?
Yeah, well, the one that I mentioned in terms of the work we did with the Chartered Society, the CSP were really, really keen for us to get underneath the skin of how we can make things work. What's a practicable solution to helping them use strength and balance? Because just like you say, 9 times out of 10, physios know the benefits. They were very passionate about that being an area of development. So at the moment, grip strength is big on the agenda in terms of supporting as a general marker for health into longer life, as well as a preventative element or skill, we could call it, around falls prevention. But the problem was, just as you say, how does it actually work? How do we get it levered in? Because we're already busy enough as first contact physios or primary care health practitioners in the broad. And on the grand scheme of things, when we did the research into the consultation process of a physio, we found they had approximately 8 to 10 minutes to be able to work with someone. And to a GP, that might sound like that's gold dust. You've got that much time. Wow. So what we did was we looked at characteristically what does that process look like, the consultation as an intervention, if we can call it that. And there are things like the fundamentals of looking at patient history, potentially exploring alternative solutions and diagnosis if that's required. And then for a physio particularly, we went into exercise rehearsal, and we broke it down fundamentally as to how much time do you spend for these things, where can we find 30 seconds here, 30 seconds there. But then equally, in what they're talking about, how does physical activity or strength and balance provide part of the solution you're looking for? Because there's that fundamental long-standing, let's say, challenge of prevention versus cure. Am I going to treat this with a pill, or am I going to treat this with the miracle pill being physical activity, if that makes sense? So that was one of the key bits of work that we've done in specific detail, the most detailed, I would say, around how do we find opportunities for you within the things that you're already doing to build physical activity into the solution. So it doesn't feel like it's an additional thing I now have to do, because that's often the reaction that we get when we have these conversations. Oh, you're giving me another thing I need to talk about now, or another thing that I've got to try and cover in my long list of. And what we used as a tool to help us do that is we used the COM-B model in a number of different ways. So it's not something that Move Consulting have for themselves, if we call it that. The COM-B model was developed by a team at UCL, University College London, led by Susan Mickey. And it's an acronym which stands for Capability, Opportunity and Motivation. And we looked at the practice of the physiotherapy staff in this case, and we explored what are the capabilities you have available to you, what are the opportunities, what are your motivations, and just worked on them to explore through those different lenses. And it did come up with some really brilliant results for them that they could take forwards, and some solutions that developed as a result of that project. So
Brilliant. So you're kind of optimizing the consultation in such a way that you can deliver physical activity, but not as an addition, as you said, but integrated into the potential solution. That's really intelligent. And what I loved was, that COM-B model, the COM, the capabilities, opportunity, motivation, the three ingredients of behavior change, something that I use a lot with patients.
yeah,
You're using it with staff, and that's actually such an important thing, isn't it? Because often we need to have some potential sort of changes in our perception and behaviors as well. So I love that.
that's the thing. Everything is a behaviour, and we take the positive light. We wear my glasses, I swear, are rose tinted. Everything is positive in the world that I live in, and it's that case of when you sit down and reflect critically on the situation, we're talking about positive impacts of physical activity, people taking on new behaviours that will benefit their health. Whereas, in the same sense, there is capability, opportunity, motivation, considerations to bring that about. There's also those same actors for what we might deem as bad behaviour or less beneficial to our health behaviour, such as smoking, such as drinking alcohol, or being sedentary. So the same elements consist in every behaviour that we see. So you can apply it theoretically to any scenario. We don't go to the degree of the absolutes of the model and go through every absolute step of the model, but there's a brilliant book that was developed called the Behavior Change Wheel that goes alongside it, where you can go right down into the detail of an intervention and understand how to design that characteristically from the most evidence-based approaches. But the COM-B model at surface level, you don't need to always dive into the detail of it. You can use it as a brilliant reflective framework, if you will. Like we say, what are the capabilities you have available to you? What's the opportunities and what are the motivations? It's a bit more detailed than that, but that's the highest level, if we could say the most simplistic level.
Many people in primary care, and I'll have to say me included, feel that kind of the current model of care delivery, which is sort of your 10-minute consultations, which are based on patients calling up with a problem and us having to try to find a solution, of course, along with the patient. They feel that that doesn't serve well for implementing lifestyle medicine because it's always problem. So let's take an example. The patient comes in with Achilles tendonitis. They're coming in because they don't want pain in the back of their heel anymore and lower part of their leg. And if I have to tell them that, look, we need to do regular strength exercises, I need you to do calf raises, I need you then to do them single leg, and then I need you to do them on on a decline. Like, this is a long process. This is going to take a number of months. They'll strengthen the muscle, they'll reduce the pain in the tendon, and it'll improve. Patients just want an anti-inflammatory drug that's going to get rid of it, at least from a symptom-based way, rather quickly. And that's where kind of the challenge comes in. Some people struggle to implement kind of lifestyle and physical activity because that's the barrier. The patient's always coming with a problem that's often reached a certain point where it's impacting their daily life. What are your thoughts about that?
Well, to be pragmatic and real about it, that is a problem. I think I heard a phrase, again, thinking back to that CSP work we did of Dr. Google, and the idea that, I think, don't quote me on the number exactly, but it was something like 60% of consultations are diagnosed via Dr. Google. And what was meant in that phrase was, you've got 10 minutes. You come with a patient who's already looked up the symptoms on the internet. They think they know. So do you spend your 10 minutes trying to unconvince them of, or do you have a positive impact on their well-being and outlook at that point in time by taking them on that journey of letting them explore what they think is the challenge for them? And I think one of the big areas that we often find the most benefit that people come to when they reflect on it is this concept of fix you. People will come to practitioners and expect that you've got a magic pill that will help them. The bit they might not be ready to realise is, in many cases, with my biases checked here, that magic pill is physical activity 9 times out of 10. That so many applications for this medication we call physical activity. So try and do more than one thing for an individual would be, if we're asking here what advice might be. Yes, help them in the situation they see themselves in and do the thing that within medical reason is going to help them take a step forward, whether that's psychologically or physiologically, but then add the additional tip of a thing that you can do long term. Silver bullets don't exist. And physical activity in its own right is not a silver bullet. There's a number of different things that you need to do, whether that be components of fitness developed and or capability, opportunity, motivation considered to build a habit. Because you can get somebody to do something as a response, but it's about building a long-term sustained change, developing a habit over time, which takes time. You can't develop a habit overnight. So we need to be mindful of that. There's only so much you can do in 10 minutes. But if there's anything I could say in summary, try and do 2. If we're thinking of a solution that meets their need at that point in time, and then add a piece of advice or an offer that might help them.
Yeah, I think that's really important, isn't it? I think sometimes we feel like we need to achieve a whole sort of shift in behavior to form a new habit within 10 minutes. We know that it's impossible to do what we're doing in 10 minutes. Yet we seem to expect the patient to be able to do that. They've entered that consultation with certain expectations. As you rightly said, often it's because they want the problem fixed, and rightly so, in the sense that, they've often how they envisage these kind of doctor's appointments, it's to get the solution, And they may have tried a number of things themselves. It's not like this is the first step on the road. So I do feel like often we need to just spread out our touch points, because many of the patients that we see a number of times. So maybe that you plant the seeds in that first consultation, and you maybe share and invite them to discuss what their thoughts are around lifestyle and in particular physical activity. And then the next time you see them, you can look to develop that a little bit further. But don't feel like you have to suddenly make them into, regular active people that are reduce their sedentary time and are doing strength training and all. Yeah, I think we have to be realistic here. These things take months, if not years, to develop, and we have to be patient.
And it's shifting sands as well, because in the same way they may be motivated by an acute issue or a feeling of pain or discomfort at a certain time that's brought them to you as a GP, that scenario that they find themselves in, that collection of elements that have brought them to you, will shift and change. So what is perceived as a problem at one point for them may not necessarily always be that problem. So there's a couple of things that we develop behavior change training for, or we have developed, and we have behavior change training that we've delivered for physiotherapy staff, first contact practitioners in the broad, whether that be GPs or otherwise. And a couple of things that we talk about that feel relevant at this point in time. One of them is instances, which is this concept that individuals in, if we were to call it a problem, that problem won't necessarily exist all of the time for them. No matter how chronic a condition might be, let's say living with arthritis, there might be instances where their arthritis isn't having such an impact on their lifestyle. So you explore, well, what makes these instances occur? Is it to do with the medication or lifestyle habits or times of a day or whatever it could be? And in that, what you're doing is putting that problem, i.e. the challenge of thinking about that, back to the individual that you're supporting. So it's their ownership, patient-centered care, a person-centered approach. It sits at the heart of that approach. Another approach that we believe, which is called solutions focused, which the solutions focused approach is basically a inherent belief that the person that you are supporting holds the capacity to find their own solution. And that's the anti to this fix problem or fix mentality that we might have subconsciously. We want to do it. We want to help our partners and loved ones and patients to get into a better place, but long-term behavior change wise, they have to be the ones to do it for themselves. So a solutions-based approach is at the heart of it. They hold the capacity to do this. They might just not be able to see it right now. And then the instances element is a great tool to help them start to explore, actually, I can do this. The old adage of how do you eat an elephant, or if you're going to start running, you don't choose a marathon straight away, you slowly build towards it. And those premises exist in loads of different scenarios, but they're two that just came to mind for me there.
That's so right. That's so right. And I remember when I first sort of set up group consultations with patients where we would have these discussions, and we have four main topics. Like the first topic, we find out about them. We call it Happy and Healthy Me. And it's just finding out what's the story, what's the motivations for being there, what are the challenges. And then in session 2, it's all around behavior change, and sort of we go through the COMB model, and we explain kind of the key elements and the sort of the science and the studies behind behavior change, etc. And a big part of that second session is about empowering the patient. It's sort of often it's that realization that I don't have the answers. You have the answers. And that's the thing, you know what works for you more than anyone. You also know what doesn't work for you as well. And it's really interesting, because then by session 3, where we cover nutrition and then 4 physical activity, you can see that they have started to take control of the groups. It's no longer me kind of giving them information or trying to educate. It's them sharing ideas, explaining what's difficult, giving advice to their fellow patients. And I think that's so important, that we need to do that shift. It's not that, we're trying to, state that we don't have the expertise or the knowledge to support. There's nothing to do with that. It's just that the vast majority of the health is going to be determined by what happens outside of the GP surgery. It's about what they do every single day. And at the end of the day, you're not going to be there, at least hopefully not, because you've got things to do. So you have to empower the patients. They have to leave feeling like they've got agency and control over their health. I think that's so important. And like I use an example of osteoarthritis. A lot of clinicians use the term wear and tear, and I don't particularly like it, because when you tell the patient, okay, this is wear and tear, it progressively gets worse, then you're removing all agency from the patient. You know, you're saying that this is just the road you're on. You're on a one-way sort of destination to a knee replacement, when in reality, and the science backs it up, is that this is just tear, flare, and repair. Patients can, through sustained physical activity, in particular strength training of the muscles around the joint, and aerobic exercise to improve fitness and optimize BMI, they can reverse a number of the symptoms. And studies have shown that. And the NICE guidance recently published in 2023 reflects that. I just hope that, you know, how we frame things for patients is so important. Like, do you find that that's an important part of your work, like framing things and how you put these things?
Yeah, without doubt. And messaging is such a key part of that. And we can, the old adage, my background prior to setting up Move, I did a lot of work directly with coaches, worked for UK Coaching, supporting organisations and individuals that are working with the least active people. And one of the lines I can recall from some of the research that we did is of that great coaching session that's been delivered, and how, as you're alluding to, the role of the coach or anyone, health practitioner working with an individual trying to support them to become more active, the priority there is to give them a positive experience. Whatever that experience is, give them a positive experience so that they can then go away buoyed on by that and do the rest of it of their own time, if you will. And the line that I kind of comes to mind for me is this: of the brilliant coaching session can be undone in a conversation for half an hour in the car on the way home, where the well-meaning dad is potentially saying the wrong things and making somebody focus on the negatives rather than the positives. So our priority in the way we frame things, and our priority in the way that we message it, is to be real about it. It's not to make it sound like it's all roses and sunshine, but we need to be pragmatic and realistic in what we're talking about, but to give those positive experiences, to show what the benefits are, and to show simplistic ways in which people can take ownership, have agency, and do what they want to do. Examples of some of the points I made there: the We Are Undefeatable campaign, for example, and a number of different campaigns like it, they're developed using lived experience of those that the campaign aims to reach. And the examples that come through using We Are Undefeatable as a specific here, they don't want to, the people that were consulted in the development of the program, they don't want to hide the reality of living with a long-term health condition, but they want to show that despite the reality of living with a long-term health condition, it is still possible to find a way to move that works for you. So that's very much about the framing and how that works. Now, connecting to health, there is the elephant in the room, if you will, of risk. That's a way of training that's been brought around, and it's sat in the background, for want of a better term, for a long, long time. So there's a lot of old ways of thinking, for want of a better term, that are hard to undo. Changing those views and changing the ways those systems are structured, that's tricky. That's hard to do. But we have evidence that helps us move forwards in that, and it's about understanding that and applying it, so it's back to that practicable solution rather than just the theory sitting there. So the consensus statements on risk help us brilliantly to frame the fact that if we're thinking about those living with a long-term health condition, the benefits massively outweigh the risks. It is more beneficial to be active than it is to remain sedentary or certainly less active. But how do we overcome some of those? I'll put it out there and just say those silly things that are happening where they shouldn't have to be. So individual comes to the GP decides or agrees with their patient that being more active might be a good idea. They go to their gym, they tick high blood pressure on their PAR-Q form, they get sent back to the GP for a sign-off. That just shouldn't be happening. but it still is. And it's because the system hasn't quite caught up and there's these little trip hazards along the way. But we're ironing them out slowly but surely, and it's getting better. But they still do exist. They still do exist. And framing how we talk about physical activity and making sure, in my opinion, that priority message remains positive is at the heart of what will breed success for us and help us create a more active nation.
Spot on. And that is a common concern from patients. I think we can't hide from that. They often worry that physical activity will make their symptoms worse or is a risk, in particular, whether it be high blood pressure or osteoarthritis. Those are classic examples where the patients are still surprised when I tell them that, we need to increase activity and work on different areas. They go, "Oh, I didn't know I could." And you just think, with high blood pressure, that is not only could, it's a must. Like if we want to get this under control without you being on umpteen medications, it's a must. And it just goes to show. But you're right. Hopefully with time, we will catch up because, the consensus statement is fantastic. I think that over the next sort of 3 to 5 years, we're going to see even more coming out with that to sort of increase the robustness of that. But I would highly recommend people, if you haven't already read the published article on the consensus statement of risk, to do so. It is fantastic and it will improve your confidence. If you are also worried, because as clinicians, we unfortunately have to practice quite defensively nowadays. There's sort of that increased concern around litigation. So I'd very much recommend reading the consensus statement. It does provide a lot of confidence.
Yeah.
Now, one of the things that you highlighted there was We Are Undefeatable, which I think is fantastic. And if you're new to the podcast, we did an episode with We Are Undefeatable. It's episode 2, and I'd highly recommend you giving that a listen. It's with Zoe, who was a patient that suffered a stroke at a very young age, but used physical activity to, really enhance her rehab, and that was fantastic. Now, talking about realistic messaging, which is what you mentioned and highlighted We Are Undefeatable as a really good example of that.
Mm-hmm.
We are seeing more and more patients knocking on our door, desperately wanting the new miracle injections that are going to fix everything. I don't know if you've heard about them, but Wegovy, what's called semaglutide, these GLP-1s, and a lot of the messaging out there has been about significant weight loss and transformative changes, which the harsh reality is, look, there is studies that show that there is improvement in weight, but they've all been done with physical activity and strict nutrition support. And probably in the reality of things, it's not going to be anywhere near as miraculous as they say. Now, when you have a patient coming to you and the expectation is they want an injection, do you have sort of much experience or any tips on how you can try to pivot things, how you can try to balance things up and try to bring in kind of a realistic approach when it comes to lifestyle advice around, in particular, weight loss, which is probably the most common thing to sort of knock on our door when it comes to lifestyle?
Yeah. Well, I guess the obvious caveat here is I'm not a GP, so I've not got any or a medical professional in any sense in that way. So I've not got any direct experience of working with a patient in that context. However, I have supported and coached a number of people in different guises to kind of come about to change and find solutions for themselves. And the bit that came to mind when you were talking there was, again, another model and approach, if you will, the miracle question. You might have heard of this, but generally speaking, the miracle question, there's a number of different ways of phrasing it, and I'll have a go at trying to recite it, if you will. But what it poses is an opportunity for somebody to reflect forwards, to use visualization in a way to help you in drawing out information to them. And the question goes to the effect, if you were to wake up tomorrow morning and all of your best hopes, and if obesity is our focus here, all of your best hopes for losing weight have been realized, what's different? And sit back and listen to their answer. And you might find that in their answer, where they've come to is that they think the solution is this injection in mind. Yet the things that they describe may offer you the opportunity to highlight different things in which they could do. It might even change the way that they think and feel about what they've actually come to you talking about. There are themes of this with regards to the early stages of motivational interviewing and other practices where you can go into a lot more detail and depth, but that kind of one step that you could take is asking that question. And hypothetically, let's explore this idea a little bit further. They might start to explain things like, well, when I'm walking up and down stairs, I don't feel as stiff as I normally do. And when the grandchildren come over, I can pick them up a little bit easier without feeling as if I'm going to lose my balance. And you start to realize that the weight loss isn't necessarily the driver. It could be, and I'm alluding in the examples here, obviously, to elements around mobility and strength. So the solution becomes, well, actually, this injection that you're after might help you do that, but it won't help you do the things that you've actually described when all of your best hopes have been realized. So the miracle questions it's a tip, but it's a good little way of approaching the conversation in a different way. And at the heart of it, as I mentioned before, it's that belief, that solutions based belief that this individual, this patient I'm speaking to, his or her name might be John or Jane. They hold the capacity to find the solution. Just as you said yourself, you're not the expert in the room when it comes to them. You don't have the ability to do everything that they want to. We need them as patients, as people, to be able to take it on themselves.
The miracle question. That is fantastic, Craig. And 100% I'm going to be using that going forward. Like often, like at the beginning of our group sessions, we ask them like, what does happy and healthy mean to them? But I just feel like how you phrase it in the sense, getting them to really reflect and think about with the problem that they've just identified and they want solved. If that is now solved, what's different? That is fantastic because it really does. And I guess you should really give the patient a bit of time to think about it before delivering an answer, because I guess it really does boil down to what truly do they want to achieve? Because you are right. When you do dig down into it, often it's they want to be able to play with the kids without running out of breath, or as you say, they want to go up the stairs, or maybe for older people, they want to be able to be independent and not rely on others and have the autonomy. I think that's really good. The miracle question. I am going to use that for sure.
And the bit to pull back to earlier on, we need to be realistic about the solutions. These are tips that I'm throwing forwards, but you've got 8 to 10 minutes in your consultation. What can you do in that time? And if it is, you've got 30 seconds, that could be a solution. The specifics, I'm going to assume that listeners may be aware of a number of these things that I've spoken about necessarily, but some of the specific information you can find about particular health conditions, you've got things like the moving medicine resources, whereby I love the design of that, where if you've got 1 minute available, 3 minutes, 5 minutes or longer, there's hints and tips in there as well. But in the frame of where we started this kind of section of conversation, if we can call it that, it's about the framing and how that message comes across. So the miracle question isn't necessarily a alternative, but it could be a way of framing some of that more, let's say, technical information you might want to deliver at a time.
From sort of the work that I've done alongside you in the past, I've always been really impressed with how you've gone about producing, let's say, reports and plans and evaluations. And it is really important from my experience when it comes to getting funding or getting projects over the line. These elements are just as important as the delivery of the service that you are trying to do. Now, what I often get asked is, they go saying, like, I want to start a group consultation, or I want to create a new pathway for physical activity in my area. But, I'm a GP or I'm a nurse. I haven't been trained in producing a business plan. I don't know what to do. I have no idea how to do a service evaluation. Now, it's putting you on the spot a little bit, but, any kind of key tips around this or support that they can get to achieve these kind of aims? If there's someone that wants to sort of start a project in their area, they're infused.
Well, the cheeky side of me is to give you the link to the website so you can come along and get in touch. But no, in all honesty,
No, but absolutely, that's part of it. Because a lot of people, that's the bit they need. They need that support.
Yeah, well, to start with, kind of just providing some information. Again, like I say, at the heart of the approach that we take and what we believe as an organisation and individuals. So, Move Consulting is myself and my colleague Elaine McNish. And we do believe in the things that we talk about. So rather than that idea of you need our help and we'll come and support you to do your review, absolutely. I'll share some details about how you can get in touch if you're interested. But to provide just some tips more than anything, the COM-B model does offer that part of solution. So really thinking about applying that in that way as to you have a service. So let's say your practice has 5 or 6 GPs and you run a couple of clinics on a day or however it might be structured. Use the COM-B model as a framework to just guide your thinking as to collectively as our team, as the people that make our practice or make our service up. And that's everyone from the cleaner through to the receptionist and the GPs themselves, let's say. What are our collective capabilities? And as we know, or as people may know, there is more to just capability. When you look in more detail as the COM-B model, it breaks down into both psychological and physical capability. But write that down. Note what your capabilities are. Think about the things that you can do, the things that you can do well, and the things that you might need help from somebody else to do. And do the same with opportunities. What opportunities are there? So we spoke briefly about the few minutes or seconds that might be free within a consultation space, but the experience that patients might have engaging with you is more than when they walk into that consultation room. There's the journey from the car park to the waiting room, from speaking to reception to sitting down, and so on and so on. So explore those as well. And then the motivations is, in one part, ask yourself that miracle question. What is it that you actually want success to be for you when you've got this program that's operating? What does it do? Why is it so successful? And the root cause or the root solution, certainly the answers to finding that solution, should come from the patients. What is it that they want that you can add as the service that you provide? And in relation to the service that we provide, it's guiding you through that process. So you can get in touch with us via our website, which is moveconsulting.co.uk. You should hopefully find a little bit more about us as an organisation and the services that we provide. But at the heart of it, you have the capability and you have the capacity to find these solutions. It's just having the time to sit down and know where to go. And it's very much the same principles that exist in the relationship between you as a practitioner and the patients you're working with. People don't know what they don't know. So guided discovery is so important. Somebody there, have you heard of Simon Sinek? I always assume everybody has. He's
No.
I hope I get this right. He's an American, might be Canadian though. I think he's American. He's an American psychologist, I believe. He certainly works with a lot of business leaders and he's all over social media at the moment. He has been for a long, long time. And one of the things that I first came across him for was his golden circle model, which is starting with why. That was Simon Sinek's thing. And essentially he used the example of Apple and their iPhone. Apple are not a mobile phone company. They're much broader than that, yet everybody knows them for mobile phones, and their solutions approach, if you will, was starting with why. What is it that will make people want our phone? And it's the operating system, the fact that you swipe up, you swipe left, you swipe right. That's why they want easy access and organisation of the information they have in their hand. That is why you will buy an iPhone, because other mobile phones are more technical or have different ways of working. So another thing that Simon Sinek mentioned that I love is there's 2 things that people need. And I've always only thought it was the first half of this. One is somebody to say that I'll be there with you and I'll hold your hand and take you on this journey that you want to go on. The second, and in running business, I've come to appreciate this more and more, is that same person to say, and if it all goes wrong, I'll still be here. And that is so powerful to me. I think that is so powerful. And if we pull that into a context on the behalf of the likes of a GP, that could be hammered home in as simple a line as providing some support and guidance and a consultation to a patient, and then simply offering, if you want to come back and see me again, just ask at reception and book another appointment. Because the assumption might be there that I come for this miracle cure, you give me my injection or my pill and whatever, and then I go away, and if it doesn't work, the door's shut. I've already tried that. I've played that card. If it doesn't work, you can come back and I'll still be here. It's alluding to and it's suggesting that there's a relationship there, which is, I would like to believe, at the heart of all good service, and all, whether that be working with a patient in your context or working with a client, building a relationship, but talking about the fact that that relationship is there, that connection is there. I want to see you again. I'll offer that you can see me again. So I think that answers. I feel as if I went off on a bit of a tangent with my Simon Sinek thing.
Really useful one.
But yeah, look him up.
Useful
He's
one.
brilliant. I love him.
And like, what I love there is actually reflecting myself on the various projects that I've done. I have looked at a why, but not the user's why. I think I've often focused on the why from a healthcare perspective, in the sense that I'm trying to reduce the impact of, for example, type 2 diabetes, or reduce the impact of cardiovascular disease, etc. But have I ever truly thought about why the patient would need this service? That's probably something that I should do more of going forward. And I think it would kind of really put into perspective the key aims of the project, because at the end of the day, it's the user that you need to engage with it, and for them to get what they want from it, isn't it? Because at the end of the day, I don't think they care about the impact that type 2 diabetes has on the primary care. That's not their problem. Their problem is their individual problem and the impact that the disease has on them and their lives. So that's really, when we're thinking about creating our plans and designing our projects, speak to the patients, like actually gather some information from them as to what is it that they want, and why would they want to attend something like that. Now, when it comes to designing, because often we need to sort of put together a bit of a business plan in order to secure some funding, or persuade our clinical director, for example, to say, yep, let's go for these group consultations with type 2 diabetes, as an example. Like, have you got any tips about how they should start with that? We know, of course, that we're going to try and delve into the kind of the whys, but like when it comes to actually sort of putting these things together, any tips on sort of creating these kind of documents, etc.? Of course, and we'll share your details in the show notes. For those that want that extra support, guidance, and consultancy from yourselves, I'd highly recommend it. Genuinely, like it is. The stuff that I've seen that you guys have done have been absolutely, really, really high quality work with the various different organizations you've done. But
thank you.
Any tips for someone that's starting off, doesn't have much of a budget, and just is doing something small and wants to get that project over the line?
Well, there's two things that come to mind. One is the word that you used, as small. So think big, but start small. Would be, I know it sounds like a business line in a marketing campaign or something like that, but it is true. So the think big idea for me is it's ever repeating circles. It feels like this conversation with regards to the miracle question idea. What is the future vision that you have that you would like to achieve? You're not going to achieve that overnight. So I always like to use a line of, what's your next best step? So that's all we can ever really know. So if we think about our locus of control, there's very little that we can actually truly control, probably a bit more that we can influence, and then there's a lot that's outside of our control and we just need to deal with as it comes to us. So when you're thinking about developing your plans, think big with regards to every possible outcome and every possible thing that you would like to do. And what I mean by big is think in the detail of that. So if it is to set up a running group, take yourself through as many what ifs as you possibly can to get that picture as to what are the potential things you need to think about. And with that in mind, once you've got that map, you want to start to just think about what's your next best step. And by next best step, that's what's the next thing that you have to do. And if you then break your program down, if we're thinking something as a larger program of work rather than an individual session you might deliver, let's say, then you might have a bit more clarity and focus as to what your ask is. So then you can be more specific. Yeah, if you only get, for want of a better term, 20% of the potential funding that you might need to get to your absolute vision, you're moving in the right direction and you're building the foundations for something bigger. So that's a key thing. And it's a fundamental of just don't try and run before you can walk. If we take, you're wearing Run Talk Run as we're recording this, so I'll use that as an analogy. The other principle is, I see it all the time, of people undervaluing the power of telling stories. Filling in a form, if you're filling in a funding form for something that's come about, I don't know, some NHS innovation money or primary care trusts thrown some underspend up for consideration, everyone can fill the form in with the information as a start date and end date, how many people you might have. And there's a very old hat way of kind of looking at the way programs are designed. Within the sector we work in, predominantly physical activity and sport, the likes of Sport England, I think it's fair to say the view used to be many years ago very much throughput. How many bums on seats? How many people are you going to reach? What's the impact going to be in terms of minutes active or whatever it could be? Whereas now it's a lot more impact focused. Yes, you might target this particular audience or prioritize this community. Yet what's the impact of the work that you're going to do be? And the impact focus changes this idea of success is driven by number, because you could have a huge impact for 10 people, yet little to no impact for 100 people. And the debate is which is better. I would like to think the former. So the way to really make any application stand out is to tell the story behind what it is. And that resonates a little bit with that Simon Sinek point around why, to a degree. But don't undervalue how powerful that storytelling can be. And the best person to tell that story are people from the audience or the community that you would like that program of work, whatever it might be, to impact on is. So get out, speak to patients, if that's our target audience we're talking about, ask them their miracle question, combine those miracle questions to give you a narrative of a story, put that in an application form, and then start your argument with your commissioning body, whoever it is, as to why they haven't. Because it does boil down to whatever we do should always be focused at the patient-centered care, person-centered practice. It's the same process and model. So it should run through everything. How we apply for money, how we build programs, how we evaluate them.
I think that's so important because, in particular, if we take that point in the evaluation, and I've done a number in my time, the bit that often people pull out and talk to me about is not the data where I show the improvements in X and Y and they see the graphs and all that. It's the patient sort of testimonials, the patient quotes, the stories. That's the bit that people connect with because that's so much more emotive and it's so much more human to understand than looking at some bar charts that show improvement in ONS scores or, EQ5Ds or whatever. Those, they don't touch our kind of, our emotional side, which as all of us want to see people do well and want to see people not suffering. And I think that's so important, adding that in. And something that I'm going to take forward from this conversation is, don't just include that in service evaluations, weave it into the proposals as well. Weave in the reason why you want to stop. For example, my most recent application was we want to set up a walking sort of a group for new parents that have prams. So we can have we were calling the pram strollers. And so we just have an access point where they can meet up, new parents, they can have healthcare professionals there. We know it's a stressful time where there's a million questions and often they, feel bad about having umpteen appointments. And so they often will, just struggle, Google, And just having that kind of weekly spot where they can connect and share their concerns, ask questions, don't feel silly or stupid if this is their first kid, which often they will feel like that. And weaving in the kind of reasons and the stories and the anxieties and all that kind of stuff is so powerful. And it's something I'm definitely going to do going forward. Thank you.
No, it's all right, that's fine. It's jumped into mind as well. It might be leaping back a little bit in what we've been talking about here, but another misconception, an area that we can provide more clarity to help understand what we mean in this kind of world, is what it means to be physically active. Telling that story as to why, because and sometimes this is about telling the story and changing the perspective and the views of commissioners, whoever they might be, and what the outcomes might be, because there's a lot of preconceptions, stereotypes that go along with this term physical activity. And from a patient's perspective, remember, people are people, we're all the same, we all have the same actors and drivers for our behaviours to a degree. And when we talk about physical activity, that's sometimes perceived as competitive sport. So you're triathlete, somebody says become more physically active, they might think, oh, you think like you, Hussein, so I've got to go legging it about doing swim, bike, run. But the reality is, be clear on those perceptions and don't assume too much that everybody thinks the same, because there are benefits to being physically active, and we love the idea of physical activity by stealth as much as conventional, let's say, structured physical activity. So if you want, as a peer, Dr. William Bird, he's a legend in this space in terms of his, and we had him on, we have our own podcast of Active Insights, and one of the conversations we had, the opening line, actually, I was editing it the other day to put it up on our Spotify channel. And he talks about patients coming into his practice many years ago now, where he had the green gym upstairs, and there's patients in to get their toenail done, and then people walk past with an axe and a bow saw because they're on the way up to chop a piece of wood on the top, because that was their green gym. It was develop your strength, brilliant, chop a piece. And people are like, I might not get my toenail done here now, because they're seeing people walk through with. But there's those ways to be physically active that don't necessarily stand out. And when we're thinking of defining our solutions by way of a program that we want to get funded, be clear about what we mean by what we'll do and be as specific as we can be, because it might not always be that idea of a traditional sport. It could be a social action group, like regenerating some scrubland or doing a litter pick along a canal. That's as physically active as playing a game of football is. It just looks different.
Yeah, like sort of neat, isn't it? Sort of non-exercise activity time, and in many ways the sort of declines in physical activity that we've seen over the decades has been in that kind of department. Because it's all the technology has removed the necessity to move just normally. I hear a lot of people, talking at the moment with the recent Netflix show about the green zones. The blue zones. These blue zones, these areas where there's a high concentration of centenarians, whether it be Sardinia or Icaria or Okinawa, etc. But the sort of similarity that it's in all those areas is not that they have high gym membership or they're all budding triathletes. It's actually the opposite. It's just that physical activity is just integrated into their lives. Washing their clothes is done by hand. Like in Sardinia, the streets are like literally at sort of 30% gradient.
Yeah.
Just going to the post office is like doing the Tour de France. And so that activity by stealth, I think that's so important. And one thing that came to mind when you mentioned that was a patient that when I was on the walk group that I do for my practice, he told me at the end, he goes, wow, I can't believe it. We've just walked 5 kilometers. I just had no idea. I was just talking away, chatting about things. I had no idea that I've just done 5 kilometers. And in fact, like the week before when we were discussing getting active, he didn't feel like he could even do more than a mile. So that's just 1.6 kilometers, And he was saying that I don't think I could do more than that, etc. But he'd finished this 5K and he'd barely broken a sweat and barely even realized that he had done physical activity.
Yeah. It can be even more granular than that, like the little things that you can do. Thinking back to that CSP project, and it's Professor Greg White. I think he's still at Liverpool John Moores. I saw him speaking years ago now at an Elevate conference. I don't know whether you've ever been to Elevate in London. It's a great clashing of two different sides of our sector. You've got the loud fitness world with all their jumping up and down and glow sticks going on, and then you've got a much quieter corner of people thinking about strategic change in physical activity, trying to engage the least active people. And it's kind of like these two worlds don't meet, but they do. They do meet. It's just that's a very stark kind of environment, if you will. But Greg was speaking there, and he talked about this. I don't think it's a theory necessarily, but he presented it as a box theory in terms of physical inactivity, where you get out of your bed in your box, your house, you go out of your house and get into your metal box, your car, you drive your metal box to the next box, your work office, and you sit down at your desk. You then open your lunchbox at your desk. And he described just a very sedentary lifestyle. Yet we can trick ourselves into thinking, oh, well, I'm active because I got up and I walked from there to there. But we're not as active as we could be. And that really, that's one of those things where it can creep up on you. Being sedentary in your life can creep up on you. You don't realize it's there. Yet step one is to break up the sedentary time, not necessarily to dive into an active behavior or lifestyle. That will come in time. And thinking practicably about what you could do, it could be as simple as in your consultation room, in your office, put a standing desk in and have a standing table. And where possible, do your consultation standing with your patient, because they've potentially gone from their box, got in their metal box to your practice, sat in the waiting room, stood up, walked in, sat back down again. So change the narrative, change the story of what that experience is like, and still have a chair in there if people need to sit down, but it might not always be the thing that people need necessarily. So just standing up can make a huge difference.
Really well said. Now, we're coming to the end, and I've got two important questions that I wanted to ask. And one is actually because one of the listeners wrote in asking this question, and I think I've got an answer, but I'm not entirely sure. So I'm going to hopefully grab your help in answering it. And that is, like, they see a lot of the term exercise, physical activity, movement, and does it really matter which one we use? Or is it just words? Does it matter more how we sort of frame exercise when we talk about it? Does the actual term we use for the sort of end kind of product that we're trying to sell, does that truly matter? Or does?
I think it does matter, because it matters to the individual on the basis of when we're trying to build rapport and communicate effectively with someone, we naturally use the language and the words that they use. So priority number one is not to look at it from a textbook definition perspective. It's to listen to the person you're speaking to and use words that make sense to them. So if somebody wants to talk about physical activity as physical activity, do that. If they want to use the word exercise, do that. Because the point is to have a conversation that you both understand and can both get benefit from. Now, that said, my perspective is, and as I mentioned before, understanding what we mean by physical activity. I have a line, we developed another little video about this called Physical Activity First. And it's because one of the things that we subscribe to, and if you go onto our website, you'll see there's a little diagram of the physical activity spectrum. And it was developed by a gentleman called Len Almond, who used to work at Loughborough University. He's no longer with us anymore. But my colleague Elaine McNish used the physical activity spectrum for one of the first times we saw it in a strategy, but in Wales for Welsh Government as part of their physical activity strategy. And physical activity is an umbrella term. And if you can imagine, we're on a podcast, so I'll get you to imagine, maybe do some, get listeners to send in their pictures of how they describe this diagram that I described. So physical activity is the umbrella. and imagine a spectrum underneath. The left-hand side of the spectrum, moving from left to right, goes from there are life opportunities to be physically active, and there are work opportunities to be physically active. So you might have a physically active job or a predominantly sedentary job. You might have a physically active lifestyle with regards to you live in a hilly area and things like that. So things that are happening. There are then opportunities to be physically active. These are often choices, but it's things like running for the bus in opportune moments where it's going to happen and occur. And then there's travel, active travel. You might go to and from places. Then you come into these terms that we see most often used interchangeably with regards to physical activity. First is play. We shouldn't forget that. And play isn't just for children. Play is for adults. Play, by definition, if we think about the recent release of the consensus statement for physical literacy, it's about how we engage with physical activity, how we learn new skills. So as an adult, play is learning a new thing. For a child, it might be, as we imagine, playing on a roundabout or a swing. Then you've got exercise, recreation, and sport. And sport can be for fun as well as competitive. Recreation is doing an activity without a competitive angle to it, hill walking, for example, or riding your bike for fun. And then exercise is that we're doing for a particular physiological benefit, of which there are others, such as developing your strength. But there are other benefits to all of this, like supporting your well-being, helping you connect with your local community. But all of those things, whether it be work, life, play, recreation, exercise, or sport, they're all forms of physical activity. So the bit that grumbles me a little bit is we read lots of strategies, and for some reason, and I can't understand why, we have this phrase of physical activity and sport, or sport and physical activity.
Very true.
Sport is a form of physical activity. It's physical activity first.
That's very true. That's a very good point. Now, we've had a fantastic hour of discussion, and I really appreciate your insights. And we will put a lot of them, I'm going to summarize them and pop them in the show notes for people, including links to Move Consulting. Now, my final question, and it's the question that we ask all the guests on my hosted episodes, and that is, there's that well-known statistic that from the 1960s, physical activity levels have declined by 20%. I want to know, in your opinion, in 20 years' time, will we be more active, the same, or less active compared to now?
Oh, there's so many ways you could go with answering that.
I know. We've had all kinds of different answers. Like, there hasn't been a general theme either.
Well, it's miracle question territory, that one, because in 20 years' time, what does the world look like? Like, I've seen Total Recall. I know what it could look like. So I think in all seriousness, to answer that question, we have to be more active. We have to be, because otherwise, why am I sat here trying to lead a business to make a difference? So if I'm to achieve what I want to achieve, it will be more active because I've done what I would like to. It's a very utopian view, but we have to be more active in 20 years' time, because the evidence shows that if we are less active than we are right now, there aren't going to be necessarily many of us left. And the way that we're working, yes, you are right. The observation is, since that observation of the bus drivers in London, we're not necessarily more active, but the world is very different to what it is now to what it was then. So the goalposts have moved, but we know more. So because we know more, we should be able to progress further. The key to making any change is consistency. We need a more stable and consistent environment to work in. And some of the things that are very positive in that sense is things like Sport England's recent strategy, Uniting the Movement. It's the first with a longer term tenure, let's call it. It's got a longer vision. So by way of Sport England remaining in place and staying there, that strategy will be delivered on for a long time. One thing that our system has struggled with has been this cyclical process that's been, back to the physical activity sport paradigm, focused around Olympic Games. So every 4 years, the funding cycle changes. And with the funding cycle changing, a whole new host of priorities come out. So everybody changes their focus. So you can't really do a lot in 4 years. And it's not really 4 because you only get 3 in, and then you start writing your new strategy for the next bit. So we have to be, would be my answer to that question.
That is a very good answer. And I hope, hand on heart, that is going to be the case. And I think with people like yourself working hard, applying your expertise, I'm hopeful as well that will be the case. Craig, thank you so much for your time and your insights. And it's been a fantastic discussion. And I hope you guys listening have enjoyed it. And as always, feel free to send in any questions that you have, and we will pass them on to Craig. And if you want to engage with him, we will leave his contact details, as long as you're happy, Craig, in the show notes.
Absolutely. We'd love to hear from your listeners to see how we can help. And thanks again for having us. It's been a great time.
You're welcome. So a really useful discussion there, and I think there's a lot of practical points to take away. Some of the chief amongst them is going to be when I go about creating future plans around some of the projects that I deliver, I'm going to make sure I get more from the service user that I'll integrate into these plans, their stories, their wants, their needs, and whether it be funding applications or a business plan, I'll embed that because, as he correctly identified, these kind of emotive stories will always resonate and connect with people. They will jump out of the page far more than any graph or statistic. And really a tip when it comes to starting these projects, whether it be group consultations or walk with the dogs, really, plan collaboratively. Think about that COM model, capability, opportunity, motivation. Do a little bit of that on yourself rather than just the patient, and work out what ingredients do you need to make this project successful. And really at the end of the day, my last tip is just do it. Just get on with it. And it will be scary, and it will be difficult, and you may well get rejected. But the process that you go on, you would have learned something. And now the mission will be about how to refine, how to improve, get feedback, and keep moving forward. I wish you the best of luck, and I look forward to joining you again soon on the Movement Prescription Podcast.